while you're listening to us for this important conversation. My name is Clarissa Taylor Jackson. I'm the Director of Programs and Outreach for NAMI Metro, and I have the distinct pleasure of introducing our speaker for this evening. So if you'll just bear with me, I have my notes here. Yes, we have the pleasure of listening to and learning from Stephanie Yee, who is a Ph.D. candidate at the University of Maryland, College Park. She researches how people with marginalized identities navigate the mental health and criminal justice systems. Her dissertation examines cognitive mechanisms of trauma and in police encounters with Black adults. As a therapist, Stephanie aspires to be multiculturally competent through pluralistic practice with an emphasis on psychodynamic and interpersonal theoretical frameworks. She provides psychological services, including assessments and therapy to children and adults at Old Town Psychology in Alexandria, Virginia. She recently began her clinical internship at Whitman-Walker Health Center in Washington, D.C. Outside of her professional life, Stephanie enjoys rock climbing, hip hop, and movies. Without further ado, I will turn it over to Stephanie. Stephanie, take it away.
Hi, everybody. Thank you so much. Yeah, I'm really excited to be here. I appreciate all of you for having me, all the folks at NAMI, Nova, and Jamie. It's been a pleasure working with you, and I guess I'll just go ahead and get started. Thank you. So if we want to switch to the first slide here. So as we've mentioned, I'm going to be speaking today about intersectionality and physical and mental wellness. So we can go ahead and swap slides. So just to provide you with a brief overview of what we'll be talking about today, I'm going to start with a brief introduction of intersectionality theory, kind of talking about what that is, what that means, and how we'll be considering it in our conversation today. Then I'm going to move into a conversation about mental health disparities and physical health disparities. And then sort of frame our understanding of some of these disparities in the context of systemic inequities and marginalization based on identity. And then we'll roll into coping and support. Next slide. So first I wanted to throw this on here just to sort of frame our discussion around identity. And I really like this just because it's very colorful. And typically when I think about different types of identities and different aspects of our lives that sort of, help us understand who we are and shape our experience, I think of color, and I think of a lot of kind of overlapping kind of colors and experiences that make us who we are. And I really like this graphic just because I think it has a lot of the traditional aspects of culture and identity that we tend to think about when we talk about identity. So you can see race, sexual orientation, gender identity, kind of all of those things that are very important, that we tend to talk about when we talk about multiculturalism. But then there are also a lot of really other important things that I think we should consider as well. Things like culture and ability and language and occupation and all of these things that shape our experiences. And so I want all of you to keep this in mind as we have this conversation today and be reflecting on some of your own identities and how they shape how you navigate the world. And I want to be clear that this infographic here and our conversation today is not going to be comprehensive. My research tends to focus on issues of race and sexual orientation. And so the way that I talk about things tends to skew kind of in that direction. And so I kind of want to challenge myself and challenge all of us to be kind of expanding on the ways that we're thinking about this, to think about other types of identities and how they may inform the conversation today. So we can go to the first slide. So to start, what is intersectionality? And I'm sure many of you have heard this term before. My field is counseling psychology, and we engage in this term all the time. We love it. It's been around for a very long time, and it's been very cool to see it kind of enter into pop culture and have more people kind of a part of this conversation. So this term was originally coined by Kimberly Crenshaw, who is a legal scholar and a critical race theorist. And so initially this came out of her seminal text in 1989. And it was essentially kind of like a critique of the way that certain movements and ideologies sort of frame the conversation. And so she originally used it to critique some of these conversations and conceptualize the unique experiences of specifically Black women, whose experiences were often omitted from feminist theory and then anti-racist politics. And so traditionally, when we think about kind of first wave, second wave feminism, especially when we're talking about, voting rights and things like that, when women earned the right to vote, it was white women who earned the right to vote. Black people were still not able to vote at that time. And so when we talk about the women's suffrage movement, that was suffrage for white women at the time. And then thinking about the civil rights movement, a lot of those conversations tend to be framed around the experiences of Black men. And so in both of these spaces, Black women consistently found ourselves kind of erased from the conversation. And so Kimberly Crenshaw kind of saw this need, and then, the birth of intersectionality came to be. So over time, we have seen intersectionality theory kind of shift and expand, kind of outside of conceptualizing the experiences of Black women to just understand the general intersection of identity and how that shapes all of our experiences in different ways. And so thinking about what we were talking about on the last slide, when it comes to race, sexual orientation, gender identity, all of these different aspects of who we are, intersectionality theory seeks to kind of understand all of the unique ways and combinations in which that informs our experiences. And so it's kind of holding two things. It's focusing on identity at the individual level, but then it's also considering the ways in which multiple forms of systemic oppression, like racism, sexism, heterosexism, ableism, how those systems place individuals in unique social locations that inform their experiences as they navigate different systems in their lives, like education system, the criminal justice system, et cetera. And so intersectionality theory kind of seeks to provide a little bit more nuance when we're having these conversations about identity. We can go to the next little thingy. So I just pulled this question on here just to get you all thinking about how intersectionality might manifest in your life. So I have, can you think of two or more of your own intersecting identities and how they've impacted your life? So if you, I think there's like a chat box. So if people want to kind of reflect on that, otherwise we can kind of, bring that conversation to the end. And I can model this for you all. So for me, I identify as a Black woman. So I kind of think about, my gender identity a lot. I think of my racial identity a lot, and I think of my age a lot. And the reason these aspects of my identity are so salient are because of sort of where I'm at in my life, in my career. As the folks at NAMI mentioned, I'm a doctoral candidate. And so as I navigate different academic spaces, I think some of those aspects of my identity become more or less salient. For example, I had to teach a class in the second year of my program. And I remember just being very, very nervous and feeling very young still. And so at that time I was like, oh my goodness, like I just graduated college and now I'm teaching college students. And not only that, but I'm, a Black woman in academia. And so, I'm sure many of us know for women of color in academia, sometimes it's very challenging to navigate spaces that historically have been predominantly white and male, and not just historically, but still today. And so, that kind of elucidates, how different spaces that we're in are going to shape the way that we're seeing ourselves and the way that people are treating us. And so I would just encourage all of you to kind of reflect on, the different intersections of your identity and kind of spaces in your life when that has come up. Okay, thank you. So this is something that I just stole from American Psychiatric Association. I don't want to spend too much time here. But this is just a little bit of, some broad information about mental health in the US, because when we roll on to the next slide, I'm going to talk about mental health disparities. And so just to start, I have a couple facts here that I found from their website that just sort of speak to how prevalent mental health issues and mental illnesses in this country are. Around 18% of adults have some sort of diagnosable mental disorder. And then 4% of adults have some sort of serious mental disorder. And I'm not going to go through the rest of the points. You can look through those. But I really want to highlight how these numbers are very likely a low ball of that, because these are people who have been diagnosed, meaning they had to go through formal systems, or whether it be therapy or, to see a psychiatrist or whatever it is. And so these numbers represent who is on paper and who has received these services. But I really want to emphasize how important it is to consider mental health, because, as we talk about depression and anxiety and trauma and all sorts of other, challenges that all of us have experienced with mental health, there are different levels of severity that people experience. And so while these are the numbers on paper, I assure you, a lot more people kind of experience symptoms of depression and anxiety and some of the other things we'll be talking about today. But yeah, we can go on to the next slide. Okay, so I kind of broke down mental health disparities into three major categories. And again, it goes beyond the scope of this presentation to talk about all of them. But I just wanted to kind of hit on some of the key ones. And I want to be clear, when we say mental health disparities, thinking about the general population and how the general population in this country experiences mental illness, disparities is concerned with the groups of people who are overrepresented in some of those, mental illness categories. And so when it comes to depression and anxiety, and I put depression and anxiety together because one, depression and anxiety is something that I think many of us have experienced in some way in our lives. But also they're the most common mental disorder to co-occur. And so oftentimes when people conduct research on, symptoms of depression, anxiety, or, official, disorders related to some of these experiences, they often go together and they're often lumped together as we try to understand what's happening for people. So with depression, anxiety, we know in general, women are at a much greater risk for both of them as compared to men. And then when we consider other aspects of identity, like socioeconomic status, we know that women living in poverty are at extremely high risk. LGBTQ plus individuals are also at higher risk for many mental health disorders, especially depression, anxiety, and suicidality. And it's important for us to think kind of in a nuanced way when we talk about this, because while LGBTQ plus folks and women tend to be at greater risk for depression, men are more likely to die by suicide. And so there are a lot of different ways that we can kind of break this down and recognize that some of these mental health challenges are impacting people in different ways. When we consider race, when talking about disparities in depression, anxiety, we know that minorities tend to be underdiagnosed with depression, anxiety. And so, I have some rates here for Black Americans, Hispanics, and whites. Whites tend to experience greater levels of acute depression. And when we say acute, that means kind of shorter, less serious kind of bouts of depression that maybe are a little bit less debilitating and last for shorter periods of time. And so while minority populations are less likely to suffer from these shorter episodes of depression than white people, they're more likely to suffer from prolonged, chronic, more severe, more debilitating symptoms of depression that have heavy consequences for their daily functioning. And this is another example of how the way that mental illness kind of impacts different groups is sort of nuanced. And so I want to bring ability into this as well. And I looked through a study that sort of looked at symptoms of depression and anxiety among people with MS, multiple sclerosis. And so this was a study published just a couple years ago, and they used a sample of 4,500 adults living in the US with MS. And what they found was that those with more severe physical symptoms associated with MS were more likely to have more severe symptoms of depression and anxiety. And so they were able to assess kind of the severity of their physical disability. And they saw that not only did they have more severe symptoms, they were also just, it was a larger proportion of them who were likely to experience depression and anxiety on any level. But what was interesting about this group of people, it was a large sample of people with MS, is that the women in the sample had higher rates of anxiety, but the men in the sample had higher rates of depression. And as I mentioned earlier, when we think about the general population, women tend to have more anxiety and be more depressed. And so when looking at this subset of a population with a physical disability, sometimes those roles can be swapped. And I think that sort of, highlights how, being differently abled or having health issues sort of is gonna, alter some of those numbers. And that's why, going back to our intersectional considerations, we should be considering all of the different intersections of people's identities and how they're shaping their experience with mental health. All right, we can go to the next slide, please. Okay, so trauma is the next big category that I wanted to speak to. As the folks that Nami mentioned, trauma, I'm kind of immersed in the trauma literature on my dissertation right now. And to be honest, it's very frustrating at times because trauma is such an elusive concept where I think traditionally, especially in academic scholarship, it's almost like the term has almost been like gatekept, where there's been very rigid definitions of trauma. And so I kind of want to share like a more general definition and then the more rigid definitions, and we can kind of talk about, what that means to hold both of those meanings. And so, in one study I read from a couple years ago, their general definition of trauma, psychological trauma, is an experience that threatens an individual's life or bodily integrity, which overwhelms their ability to cope by creating feelings of hopelessness or intense fear. And so obviously based on a definition like that, we can think of a number of experiences that we could classify as trauma. However, when we look at formal diagnostic systems, like the DSM is what we use in counseling and clinical psychology, they have much more specific, rigid definitions of trauma. And so in that diagnostic system, their definition of trauma is actual or threatened death, serious injury, or sexual violence. And so, of course, there are a number of benefits to having very rigid definitions for how we're talking about things. Obviously, we have to have boundaries on something so that we can, make meaningful conclusions about it. But at the same time, when we're using rigid definitions like that, that sort of omits from the conversation a number of other types of trauma, like racial trauma, like discrimination and things of that sort that, folks of color or LGBTQ folks experience on the daily and maybe have, similar symptoms like we see with traditional PTSD. And so I just kind of wanted to put that out there so we could be thinking about trauma a little bit more expansively, while also recognizing the way that much of the literature talks about, PTSD and trauma. Okay, so going into the disparities, we know that, again, women are overrepresented when it comes to PTSD diagnoses than men, especially women living in poverty. I think that's going to be a theme that comes up today a lot, is that socioeconomic status, which is, I would say, one aspect of identity as well. That's just kind of going to show up all over the place. It's, again, there's a lot of overlap, and that's why we need to talk about them, kind of at the same time. Some research suggests that LGBTQ plus youth are 1.5 to 2 times as likely to experience a violent event in their life. And this often comes up during childhood. And so a lot of the literature kind of focusing on LGBTQ plus folks is going to focus on trauma to better understand, strengths and or protective factors and things like that to help to figure out kind of what are the underlying causes of why this specific group is experiencing that. And then thinking about kind of even anecdotally, I guess, thinking about current events that happen in the news. When I think about the number of articles I've read about trans women of color being murdered, the Orlando shooting, which happened in 2016. It was a gay nightclub. It was gay people who were targeted. I think even anecdotally, we see that in the news. And so think about people in the LGBTQ plus community who are seeing people like them getting targeted. Of course, that's going to impact the way that you are living and how safe you feel navigating the world. And so I think situations like that kind of are very important to consider. Thinking about race and ethnicity, people of color experience largely disproportionate rates of PTSD. So they're more often diagnosed with PTSD, and they have more severe symptoms of trauma compared to whites. And so the way that I frame that in my research is around racism and discrimination, which is arguably, largely traumatic for people of color, Black and Indigenous people. But then there are other kind of overlaps that come into play, like socioeconomic status and poverty, and of course the traditional forms of trauma, the traditionally considered forms of trauma, like military combat and sexual assault and natural disasters and things like that. Yeah, looking through the DSM, they list risk factors for trauma, and they include living in poverty, and they include racial ethnic status as a risk factor for PTSD. And so if you're born in the world as a person of color, psychologists consider that as a risk factor for developing, this disorder. American Indians and Alaskan Natives report the highest rates of PTSD than any other racial ethnic group ever. And so I kind of want to wrap up this slide by talking a little bit about intergenerational trauma and soul wounds, historical trauma. These are slightly different concepts, and I'm kind of going to smush them together because there is a lot of overlap. And this is just something to consider that kind of helps us understand maybe why a lot of folks of color are overrepresented in folks experiencing trauma and PTSD. And so for those of you who aren't familiar, intergenerational trauma and soul wounds refers to the cumulative psychological wounds that result from historical traumatic experiences. And so this can be colonization, genocide, slavery, dislocation, other related trauma. And so again, the major study that I'm working on right now is concerned with police violence. And so I'm conceptualizing, and scholars have started to conceptualize police violence against racial ethnic minorities, specifically Black adults, as a form of trauma. And you can sort of think about that almost as an intergenerational sort of thing, where I'm sure many of you have, read a story or had a conversation with someone who, someone who has Black parents or something like that. And I think many of us know that Black parents are tasked with the horribly sad task of preparing their Black children to stay safe around law enforcement, because we know that law enforcement disproportionately targets young Black men. And so, this is an example of racial socialization, how parents are teaching their children how to navigate the world as people of color, as Black people, but also it's arguably transmission of that trauma that Black communities have faced at the hands of law enforcement. And so even just passing on those messages, I didn't talk about the symptoms of trauma, but kind of the typical hypervigilance, nightmares, flashbacks, intrusive thoughts, living in fear, things like that. And I think, the most notable thing there for me is the hypervigilance. When you're living in certain communities as a darker skinned, Black man or woman, there's going to be a certain level of hypervigilance that you might experience when around law enforcement. And I'm not saying that's the case for everybody, but for some people that is the case. And that's a symptom of trauma. And so I guess going back to my initial point about trauma and the way that we're defining it, I think it's really important to be expanding the way that we're talking about it and thinking about the different ways it can manifest in different people's lives. Because thinking about police brutality, police violence as a form of trauma is relatively new in my field. And I think it's definitely a conversation that needs to be had. All right, we can go to the next slide, please. Okay, and then this is the last major category I have for mental health disparities. And just to touch on substance use disorders, kind of across the board in all of the literature I look through to prepare for this, poverty is a #1 risk factor. And so folks who are low income, unfortunately are more likely to, have substance use disorders. LGBTQ plus individuals especially are at higher risk for substance use disorders. So I'm sort of going to focus on this group here. I looked through a study of racial minority young men, men who have sex with men. And so again, thinking about intersectionality, this is POC, and it's also LGBTQ plus people. And so in this sample of young people, 44.9% use cigarettes. And this is, young people. I don't have the numbers here, but I think the sample was like 18 to 30 or something like that. So yeah, 45% use cigarettes. 82.4% used alcohol, and 65.3% used marijuana. And in studies that compare LGBT groups of people with straight groups of people, time and time again, LGBTQ plus people are engaging in substance use and having substance use disorders at a higher rate. Additionally, to kind of think about this even more nuanced, bisexual men across the board tend to report significantly higher rates of stimulant use. And this is kind of consistent with many studies that I've looked through looking at drug use in LGBTQ communities. And so that's just an interesting thing. It's not just bisexual people, but specifically bisexual men. And so kind of thinking about this from a mental health practitioner standpoint, this is important information for us to know so that we can understand, okay, like what might be some of the risk factors that, these particular groups are dealing with. And then again, kind of bringing race into it a little bit, American Indians and Alaskan Natives report higher rates of alcohol dependence than any other ethnic racial group. And I guess kind of circling back and bringing it back to trauma, we can come up with a number of reasons why certain people in marginalized groups are needing to cope with substances because of the traumas that they face, because of being disproportionately impacted by poverty and racism and all of the stress that comes with that. So yeah, I guess we can move on to the physical disparities slide. Okay. I really like this infographic. I really like the colors. So if we could just click one more time. So physical health disparities kind of similar to mental health disparities when folks in certain groups are overrepresented. And then this is something that comes up in the research a lot, respiratory diseases, HIV, diabetes, asthma, heart disease, et cetera. And so kind of think about some of these things and that's sort of kind of what I'm going to be talking about here. And we know that for, at least in this country, influences on health include availability and access to education, nutritious food, decent and safe housing, affordable public transportation, healthcare, health insurance, clean water and non-polluted air. There's a number of things that are very important for our health. And so, this is another big one that socioeconomic status is a huge, indicator of, because people with limited access to some of these resources are likely to get sick more often, right? Because they can't get to the hospital, they can't afford the hospital, whatever it may be. Recent research has found a very alarming difference in life expectancy when we look at the top 1%, economically, the top 1% of people in the country who have the most money or whatever, and then the bottom 1% based on income distribution. For men, that life expectancy difference is 15 years. And for women, that's 10 years. That's a lot of years. That's huge. That's really sad. And so when thinking about some of these other groups, I think poverty and capitalism and healthcare are sort of the underlying, institutional reasons, for these disparities. And we're going to talk more about kind of some of the reasons, because I really don't want folks to take from this, that it's in any way a deficit of people who are marginalized. It's a deficit of a problematic system, but we can get into that a little bit later. So kind of bringing it back to race, Black people are more likely to have underlying conditions, Black people compared to white people, like diabetes, asthma, heart disease. They're more likely to test as HIV positive compared to whites. Black LGBT individuals suffer higher mortality rates from diseases like breast cancer, heart disease, diabetes, HIV, etc. And so not only are people of color, Black and Indigenous people, and Black LGBTQ people more likely to have some of these diseases, they're also more likely to die faster from these diseases. And I guess bringing it into current events with COVID, I'm sure many of you have viewed some recent articles about how COVID-19 is disproportionately impacting poor communities and communities of color, specifically Black communities. And if we're viewing it through the lens of physical health disparities based on race, it's going to make sense, right? Because the CDC says that people who are dying from COVID are largely, you know, people who are older, largely people with pre-existing conditions. And so when you have a system that's messed up, where Black people are already dying at greater rates from pre-existing conditions, and then we have a global pandemic on it, they're going to die at disproportionate rates because they're already susceptible to that, right? And I think, you know, poverty and all of these other things are things that kind of are playing into that as well. So if we can just slip once. And then one thing I haven't spoken about is like region, I guess. And obviously region isn't an identity, but it is something that shapes people's experiences. So I kind of want to bring this into the conversation. And so this is just a picture of protesters fighting for water justice for Flint, Michigan. How long has it been that Flint, Michigan hasn't had acceptable, you know, drinking water? These environmental factors are also important to consider. If we could go to the next one. And then also, you know, the fires, the fires in California. I think it's every other day that we see a new story of you know, this state burning down. LA County remains one of the most polluted regions in our country. And we know from research that prolonged exposure to air particle pollution is going to lead to increased risk of death from cardiovascular and respiratory diseases. And so I think it's important for us to not only consider race, sexual orientation, ability, SES, but also consider kind of the regions and the environmental conditions that people are living in. Okay, we can move on. Okay, so, and this is my favorite slide, and I think like the most important slide and the most important thing that I want folks to take away from, because again, I think especially in this climate now, it's really easy for people to take a piece of data and say, all right, this is my piece of data, right? And I'm gonna view this piece of data through the lens that I already view the world in. And so if someone has like a bias or, you know, whatever of people of color, people in marginalized groups, they're gonna see the data that I just shared with you all from the other slides and somehow use that to confirm their bias. And I really, really, really wanna make clear that these disparities exist because of problematic systems. And so let's get into what that looks like. And I have 4 major points here. And this is something that researchers and advocates and politicians and whatever have been interested in for a very long time. And so there's a lot of information about this, and we don't have time to go through all of it. And I just pulled up 4 main points that I really wanted to drive away. Because it's important for us to understand the antecedents and the consequences to these disparities so that we can better serve ourselves as well as the communities that we, you know, from a mental health practitioner standpoint, the communities that we're trying to serve, right? So the first point I have on here, kind of already touched on it a little bit, speaks to socioeconomic status and access. Kind of like I was talking about before, as we know, Black and Brown people and other minority groups suffer disproportionately from poverty. And so people who are low income have limited access to resources like high quality medical care, transportation, all the things we were saying before, health insurance, the big one. And so when people don't have access to these basic necessities, they're less likely to receive the preventative care that they need, and they are more likely to get sick. And so that's, you know, obviously a huge one. The second one I have on here speaks to microaggressions, discrimination, racism, and stress. So obviously the socioeconomic stuff is extremely important. However, research that's kind of tried to examine different factors that lead to some of these disparities that we see kind of seek to control for factors like socioeconomic status, housing, all of these kind of bare bones necessities that we need. And so, you know, even in studies where they look at these factors and they are able to control for them, meaning they're just able to kind of, they are able to see the impact that they have, but kind of push them out of the equation. And even when they push them out of the equation and control for those factors, these disparities still exist. And one popular kind of guess for why this is kind of this topic here. And so, you know, I'll focus on microaggressions. I'm sure many of you heard of microaggressions, so I'll go over it very quickly as just kind of the brief, commonplace daily verbal or behavioral kind of assaults targeted at a minoritized group. And so these, while small to some, have a cumulative effect. And so they happen over and over again to people, and it has a cumulative effect on people's health, on people's stress. Even if we're talking about more overt forms of racism and discrimination, that chronic stress that people of color and people in other marginalized groups are living in takes a literal physical toll. And so I tend to look at things from a psychology perspective, obviously. But the last class I had to take was a neuropsych class. And so if we have any neuroscientists, please help me. But one thing that stood out to me that I learned from that class, I had to write a paper on, I made it about racism and discrimination. But I learned about some of the neurocorrelates of racism and discrimination, how that actually impacts people's physical health outcomes. And so one specific example, there's this thing called allostatic load. And this occurs as a result of excessive amounts of stress. So it doesn't have to be race-related stress or, you know, discrimination-related stress, any type of stress. And so if an individual is under constant stress, allostatic load occurs, and that can manifest as chemical imbalances in the brain or a degeneration of brain structures. And that can result in a speeding up of the development of disease like cardiovascular disease, depression, and obesity. And so people of color who are, you know, going back to the trauma thing and who are living hypervigilantly, who are experiencing daily microaggressions or racism or trauma or whatever it is, you know, that heightened emotional state that people in minority groups find themselves in, that could lead to allostatic load and have very, very clear, tangible consequences for their physical health. And so that's another thing, you know, to think about even outside of lack of access and care, is the actual what's going on inside our bodies when we're experiencing, you know, racism and discrimination, all sorts of forms of discrimination. So my next point is about discriminatory practice among medical providers and mental health providers. So we see this in my field as well. Microaggressions that occur in my field and elsewhere, and kind of how that can be debilitating for people and can limit their access to care. And so one study that I wanted to talk about was a study where physicians were providing services to a group of Black patients and a group of white patients. And everybody involved were equal contenders for bypass surgery, I think it was. And they all, it was medically relevant for them to receive this. And so in the study, they assessed kind of the doctor's decision-making and kind of how they perceive the client. And across the board, the doctors were less likely to suggest a necessary medical procedure for the group of Black patients as compared to the group of white patients, because they believed that the Black patients were not going to, they endorsed stereotypes like, you know, they were going to be too lazy to follow post-surgery instructions, or they weren't going to understand, or this and that. And so, you know, and I want to be clear, like, it's not like people are being intentionally racist at all times. I'm sure these doctors thought they were doing their due diligence and making decisions based on their clinical judgment. It just so happened that their clinical judgment was infected by racial bias. And so they were making decisions informed by stereotypes against the Black clients or patients, and then making relevant medical decisions based on that. And that, you know, resulted in them, you know, not getting the treatment that they may have needed. I was going to mention another study, but I'm mindful of time, so I guess I will move on. I guess I'll just quickly say I was on an audit study where we looked in my field at people searching for we had like a fake actor client who was trying to reach out for services from therapists and clinicians kind of all across the country. And what we found was that when the patient had, when the patient had, more black characteristics, like we had a, stereotypical black name and this and that versus more stereotypically white name or whatever, they were less likely to be called back. And so even in my field where we really praise multicultural competencies and diversity and inclusion, we're subconsciously, limiting access to care for, certain clients based on the color of their skin. And so time and time again, we see that this is happening. So there are barriers coming from the institutional side as well. And then lastly, my last point kind of pulls much of this together. When it comes to underutilization of services, time and time again, we recognize that Black, Indigenous, and people of color and LGBTQ plus communities tend to underutilize mental health services. And I think it's for all the reasons that we're talking about, because of microaggressions, that they might experience from practitioners, or, the treatment wasn't multiculturally competent. We know a lot of our systems are based around Western standards of medicine and practice, and that's not going to serve the needs of all clients. And so you have clients whose needs aren't being met, and they're not going to reach out for those services. And that allows some of these disparities to persist. Okay, we can move on to the next slide. So how can we cope? I just threw a lot of sad information at all of us. So let's kind of bring it back to us and think about, for some of us who are dealing with some of these challenges, maybe ourselves, or who are supporting people who are dealing with these challenges, what can we do? So the first thing I want to hammer away is seeking out professional help. This could be in the form of support groups, therapy, kind of to my point before, it's really important that we could do the next, the therapist is multiculturally competent, right? And so if you are in need of help, I suggest that you reach out. Psychology Today is a really good tool. They have a find a therapist tool where you can type in your location and all sorts of information to kind of your insurance and all of that to find a therapist who works. And so I think, especially if you're a person of color, or if you are, have disabilities, or if you are queer, it's important to be looking at folks' page and trying to find the buzzwords like diversity and multiculturalism. And, because if they're going to slap that on there, it's not to say that they're going to be perfect, but at least they care enough to put it on, and they care enough to say, hey, this is a priority for me. And I would encourage all of you to try to consider that when seeking out for help. We can go to the next one. Community involvement, I think, is really important. Webinars like this, I hope that this was somewhat informational for you all. I think this is you getting involved in your community and engaging in information that impacts all of us. And so I think that's a great way to do it. I think community activism is a great way to do it. I know that we are in the midst of a global pandemic, and we don't always feel comfortable going out with the signs and everything. And I recognize that that's not safe for everybody to do that, but there are other ways to get involved. Really quickly, there's a concept called critical consciousness that's really popular in my field, which sort of speaks to, it's kind of twofold. One piece of it is an awareness of systemic inequity. And then this next piece is our subsequent action that we take to dismantle those systems of oppression. And so it's the awareness and it's the action, and smushed together is critical consciousness. And time again, we study critical consciousness, and it's found to be a protective factor for people in minority groups. And so if you're working on fostering your critical consciousness and you're getting involved in your community, that might be helpful for you in kind of coping with some of the stuff that we all are coping with right now. And that's not to say that, you have to be fighting all day, every day, because you should certainly be taking care of yourself. But that might be something to kind of continue looking into. And I think, all of you have demonstrated that as the first step, I guess, or a part of your journey and continuing to be involved in your communities. Okay, and then we have social support. Social support is also found as a protective factor, unsurprisingly. Please lean into your friends and your family and your community. Please, it's very important. I know that has really gotten me through this pandemic, is my wonderful friends and my wonderful family, is to really lean into those that you love. and we can go to the last one, while also being mindful of your own needs and your own boundaries. And I would say that this last piece is arguably the most important piece, the self-care and the boundaries. And I have a little picture of a lady with plants because that's my thing, and the face mask. But self-care can take many forms, right? I think our traditional way we think of it is like you're in the bath and you have a glass of wine if you're of age, and that's how you engage in self-care. But I would encourage you to expand the way that you are thinking about how you can prioritize yourself, because you're not going to be able to support your friends and family or support these communities if you're not taking care of yourself first. And I think that's where boundaries comes in, where it's extremely important to be intentional about being honest about your own capacity, especially if you find yourself kind of being a helper or being a supporter or a caretaker for people. That's lovely. It's wonderful to be in that role, but it's important to check in with yourself and make sure that you're, making sure that your needs are met, and putting up boundaries and, getting space when you need to do that. And yeah, that's it. I think I just have like a thank you thing, and yeah, thank you all for your time. I saw a lot of comments pop up and I was looking at a million things, so maybe we can engage with some of those. But yeah, thank you all so much for the time and space.
Thank you, Steph, so much for that really, really informational presentation. I feel like I just learned so much, and I just want to go back and rewatch the whole thing and just let it all soak in even more. But yeah, right now we are happy to take any questions from the floor. You're welcome to drop them into the Q&A or into the chat. If you had a question before, we can check those out.
While you're waiting, for those of you who are looking in the chat, I did drop a link to the Black Mental Health Alliance that gives direct referrals to clinicians. So that is a good resource, but Psychology Today really is the best resource to use, because you can search by your zip code for clinicians in your area by the whatever specification you're looking for. So.
Mm-hmm.
Oh, could I add, this was something that I forgot because I was getting panicked because I ran out of time. But another really helpful resource is for folks who are living in the Maryland area who don't have insurance or who have crappy insurance, pro bono therapy project. That's something that I've referred a lot of clients to. That's something that I've used personally. Even if you have insurance, call them and just say that it doesn't have a good mental health copay or option, and they'll set you right up. They'll set you up with free or low cost services. And there are all sorts of different clinicians in the area. Again, that's pro bono therapy project. You Google it, you can call them, and then they screen you and they pair you with a therapist in the area.
Yep. That's actually one of the things that we tell people about all the time on our helpline too. I think it's the Pro Bono Counseling Project, but they are really great. The fact that they offer that, lower cost or free mental health service to folks is really important. All right.
There is a question in the chat, Stephanie, I don't know if you see it. It's from Sonia, who says, I'm also curious to know more about allostatic load.
Yeah, me too. Yeah, no, that's the one thing that I really cannot speak more to. If I don't know if folks at NAMI are sharing these slides, but I do have citations for everything that I discussed. And so the papers that I looked at with allostatic load and stress and that sort of thing are in there. I'd also be happy to share my email, and I could share the PDF of that with you. It just kind of speaks more in depth, much beyond my capacity.
Yeah, no, I think that would be great. If you don't mind sharing your info, and then we can absolutely follow up with everybody who's been here today when we say thank you and everything, and just send that along if you're comfortable with that stuff.
Yeah, absolutely. Please do.
Awesome. Thank you. Yi seems excited about that too. Great. All right. Well, do you have any closing remarks, Steph?
No, just I'm happy that folks, were we're on for this academic talk this late into our evenings. I think it's really important, and it's nice to see, you know, everybody online here and giving this the space. And I appreciate the folks at NAMI for having me on. Thank you, Yi-Chen.
We did want to, if there's nothing else, we did want to share some of our upcoming events. We have we're chock full of activities really quickly. Nova, I didn't know if you wanted to share your screen really quickly too.
Yes. Here we go. Oh, those are all the references that you all can look up. And these are our upcoming events that we have for the rest of I Will Listen Week. Please remember that this is happening all week long, October 4th to the 10th. We've got trivia coming up on Wednesday. There are some prizes that you can win, so please get involved, tell your friends, bring your family, whoever. And we've got a writing workshop coming up tomorrow. That's going to be a great experience. Under Armour is giving away free swag bags worth like $100 in their Flourishing mental health webinar. So feel free to join in on that. And as we mentioned, and we're also having a How Are You Really mental health fishbowl on Friday, October 9th, which is going to be a more interactive discussion where we'll have breakout sessions. People can talk about how they're really doing, because that's the whole point of I Will Listen Week, is to just talk and listen to each other and focus on our mental health. And then on Thursday, October 8th, we've got Active Mic going on with Kai Roberts. He's going to be telling his personal journey with a mental health condition with hip hop. So Steph, I hope to see you there because you like hip hop. And then of course on Saturday, we've got a pop-up young adult support group, and anybody is welcome to join. We encourage you to spend that hour and a half with our wonderful volunteers who lead that group and just create a safe space and environment for people to open up and talk about how they're feeling and find support in one another.
And I am dropping a link in the chat. If you do attend that Saturday support group and you find it interesting, or you can't attend that support group, but you would like to engage with our regular second and fourth young adult support group, I'm about to drop a link in the chat. Just a quick little survey so that you can fill it out. And if you want more information, it's like 3 questions. If you want more information about our young adult support group, a staff member or a volunteer, a facilitator of one of those support groups will get in touch with you. So the link is in the chat.
Yep. All right, everybody. Well, I hope you all have a wonderful evening, and thank you so much for joining us. And thank you, Steph, so much for your time tonight. I think we all learned so much, and I don't know, we just have a better understanding of the world and also of ourselves too. So thank you so much for giving us that. Have a good night, everybody.
Bye.
Bye.